Kia ora koutou. Ko Matairangi te maunga, ko Waimapihi te awa, ko Humboldt te waka, ko Pakeha te iwi. No Horana, no Tene Makua oku tūpuna. No Wanganui Atara aho, ko Robin Smits, rua ko Peter Aagaard oku mātua. Ko Nicholas Aagaard taku ingoa, no reira tēnā koutou, tēnā koutou, tēnā koutou katoa. Welcome everyone and thank you for coming here today. Again, my name is Nic Aagaard. I'm the Principal Advisor for Ethics at the Ministry of Health. I've been at the Ministry for over 7 years now. I do all the things that Rob explained, providing advice to various groups. The one thing that I do a little bit differently also is work for the Global Ethics Unit at the World Health Organization, so doing a little bit of international work as well. For the last 2 years, I've been working primarily with the National Ethics Advisory Committee on 2 projects. One was the development of these national ethical standards, and the other was New Zealand hosted the Asia Pacific regional meeting of national bioethics committees. So we got a chance to discuss these standards with about 38 other countries from the Western Pacific region. And we're also going to be presenting these standards, which we consider a world first in terms of our Partnership of Principle in Portugal in a couple of weeks. So looking forward to that as well. My background is in bioethics and philosophy. So I have a master's in bioethics, and I'm currently doing academic work in the ethical challenges faced by learning healthcare systems. So some of the things in this NEAC document are of great interest to me, particularly looking at data use, integrated research or embedding research into routine care, and particularly looking at ways that we can modify informed consent. So I'll be excited to hear your views around that today. So I'm going to start off with explaining what ethics is, and in particular the foundations for ethics, of which there are many. I'm going to explain why research ethics matters, particularly in New Zealand, and then I'm going to introduce the Partnership of Principles. I will explain some of the highlights of the NEAC standards where possible, and show you some of the new concepts and new standards that we have here now in New Zealand. I'll also be doing a bit of looking forward at the changing research ethics landscapes. Ethics and research is constantly evolving, and so we're trying to keep ahead of this and communicate some of the changes that you might start to see over the next 5 years. Somewhat due to the health research strategy and somewhat due to international and national developments. So we're here today on behalf of the National Ethics Advisory Committee. For those who do not know, NEAC was established in 2001, and they are an independent advisor to the Minister of Health, and they have a number of statutory functions, one of which is to advise the Minister on any ethical issue for any health and disability matter, so they are a bioethics committee generally. But they're also tasked with determining nationally consistent ethical standards across the health sector. It's important to note that this isn't just for research, and that's been evidenced in our national ethical standards that also cover quality improvement. And we are picking up some of the work in clinical ethics as well and developing our capacity there, as we have some potentially significant moral considerations coming through the euthanasia bill. So, you know, it's a really broad focus that NEAC has. Fortunately, we're staffed with some amazing people. Today we have Marianne Woodnorth here, Gordon Jackman, Kahu McClintock, so it's fantastic to have a few members here in the room. This project spanned, you could say it started in 2015, so we've got prior members of NEAC who have come and gone since this has been published. In particular, I want to acknowledge all the people that were involved in creating this document. So first and foremost, the members of the National Ethics Advisory Committee. Developing this document, we had a number of ways of working, one of which was to establish a Ministry of Health working group with the terms of reference, who were tasked with effectively belting out a bunch of the content over the course of a couple of months. So we have a number of working group members here today as well. I want to acknowledge their work, and in particular the work of Barry Smith, So Barry Smith was on our working group and he passed away before the document was published. We've got an example of some of Barry's work a bit later today, but his contribution was invaluable to their development. The staff at the Ministry of Health, Ethics Secretariat, the HQSC, Health Safety Quality Commission, invaluable to learn about the ethics of quality improvement, a little bit of a different ethics framework there, but as we'll see a bit later today, really important to consider the ethics of those activities as well as health research proper. We had over 165 submitters during our public consultation, and we worked with other researchers and government agencies as well. Okay, so foundation of ethics. So ethics, also known as moral philosophy, seeks to address philosophical questions about morality. When most people think of ethics or morals, they might think of rules for distinguishing between right and wrong. For example, the golden rule, do unto others as you would have do unto you. Or you might think of a code of professional conduct, like the Hippocratic Oath, first of all, do no harm. Or a religious creed like the Ten Commandments, thou shalt not kill. Ethical norms, such as you should not kill, are so ubiquitous or obvious that we might be tempted to regard them as simple common sense. On the other hand, if morality were nothing other than common sense, why are there so many ethical disputes in our society? Well, one plausible explanation for these disagreements is that all people recognize some common ethical norms, but they interpret, apply, and balance them in different ways in light of their own values, life experiences, and culture. For example, two people could agree that murder is wrong but disagree about the morality of abortion because they have different understandings of what it is to be a human being. So ethics is about identifying ways, using frameworks, of which there are many, to understand moral problems or disagreements. Bioethics is a subset of ethics, and it's about looking at the ethical issues that emerge from advances in biology, medicine, and technology, and in particular, the issues that arise from the relationships among life sciences, biotechnology, medicine, politics, law, philosophy, and theology. Finally, health research ethics is a subset of bioethics, and it's about navigating the ethical tensions that are inherent within all cases of health research with human beings. So where did research ethics come from? Well, in the West, it was born from tragedy. Research with human beings has improved healthcare steadily since the first clinical trials were conducted in the early 1930s. Our standards of care have developed and been better understood through research and enable many to live healthy lives. However, the history of medical research is marred by exploitative and dubious human experimentation. And in the wake of each disaster have come new and improved rules, protections, or expectations for conducting research with human beings. So this is an image of 16 doctors and administrators who were found guilty of willing participation in the systematic torture, mutilation, and killing of prisoners in experiments. During the war, atrocities were conducted on thousands of prisoners in the name of scientific knowledge, and in particular, disabled people were targeted and exploited, another feature that we've addressed in these NEAC standards. The trials highlighted highly unethical medical research conducted by Nazi doctors on the many captives in the concentration camps in World War II, and following the war in 1947, at the Nuremberg trials, the Nuremberg Code for Ethical Research involving human subjects was developed, marking the first international code of research ethics. But having a document published or rules or standards being out doesn't automatically result in ethical research. Even with the Nuremberg Code established as an international document following 1947, large-scale unethical research, in this case with US government support and funding, was conducted. So this example here in 1932, the Public Health Service, working with the Tuskegee Institute, began a study to record the natural history of syphilis in the hopes of justifying treatment programs for African Americans, and it was called the Tuskegee Study of Untreated Syphilis in the Negro Male. The study initially involved 600 African American men, 399 with syphilis, 201 who did not. Researchers told the men that they were being treated for bad blood. This was a local term used to describe several ailments, including syphilis, anemia, and fatigue. And in truth, they did not receive proper treatment needed to cure their illness, and in fact, during the study, penicillin was developed as a cure, but not given to participants in exchange at all. Now, in exchange for taking part in the study, the men did receive a few things. They had free medical exams, they had free meals, and they received burial insurance. There was no evidence that informed consent had been given to the participants, given by the participants. They were not given adequate treatment for their disease, and now of the 399 participants with syphilis, 28 men died of syphilis, 100 died of related complications, 40 wives were infected, and 19 of the children were born with congenital syphilis. The study ended in 1972, 40 years after it began. Initially, it was meant to run for a couple of months. It only ended after an Associated Press story about the Tuskegee study caused public outcry that led to the then Assistant Secretary for Health and Scientific Affairs to appoint an ad hoc advisory panel to review the study. The result of this in the US, they created the National Research Act, which then established the National Commission for the Protection of Human Subjects of Biomedical and Behavioural Research, and developed the Belmont Report, which is the leading US research ethics report of the time. The Belmont Report also put substantial work into developing some of the Western bioethical principles that we do have adopted here in New Zealand. So this ebb and flow of tragedy in the West in particular, and then development of stronger protections and guidelines has continued over time. And we have a number of international codified universal principle documents. So a few examples are up here on the screen, but they all have something in common. They purport that the universal principles in these documents should guide practice in order to conduct ethical research, so to protect research participants while also generating good, such as generalizable health information. These principles are adapted to form a range of internationally recognized codes, the Nuremberg Code, the Belmont Report, the Declaration of Helsinki, and in New Zealand we also adopt some of these universal principles that feature in our code, such as the Code of Health and Disability Rights, Consumer Rights, and the Health Information Privacy Code. The most recent document that we looked at closely during the development of NEAC document is the CIOM's International Ethical Guidelines. Now, CIOM's mission is to advance public health through guidance on health research, including ethics, medical product development, and safety. Now, this document also brands itself as universal, and it's fair to say that these guidelines present a gold standard. If you look in the first front pages, the number of acknowledgements they have are numerous and many. They had top people internationally developing this document. However, when developing it, they don't have to adhere to local culture, local laws, or local values. So it is useful for a starting point, and I'd say our national ethical standards are very much in line with international thinking. However, we only use them as a reference point. This is because ethics in New Zealand has another history, finding morality through tikanga. The primary Indigenous reference for Māori values and ethics are the creation stories, which highlight specific relationships that are deemed fundamental to the sustainability of life. These relationships are embedded as kawa, or primary values, and provide the framework and foundation for the establishment of tikanga. Tikanga are locally specific practices that aim to enhance these relationships and ensure the preservation of mana, justice, and equity reflected through power and authority. As the environment changes or new situations arise, tikanga are enacted or adapted to provide context-specific responses. So kawa and tikanga provide the primary interface for accessing repositories of cultural knowledge and experience that can be used to inform ethical deliberations. Tikanga also provide a framework through which Māori can actively engage with ethical issues and can consider the effect of the research that it may have on their values or their relationships. We also have the Treaty of Waitangi, which we'll hear about in more depth later today, but this is something unique and of pivotal importance when considering our national ethical documents. The treaty partnership provides the opportunity to design together an advanced national health and disability research ethics platform that actually encompasses the two world ethical views, that of Western ethics and that of tikanga Māori or Māori ethics. These standards extend the work of previous committees in that they now incorporate tikanga Māori and they make more logical links between Māori research, theory and practice, and in doing so they're consistent with the strategic priorities of the New Zealand Health Research Strategy, which again is founded on the treaty. So when I'm talking about universal ethics here, one of the issues around having a universal approach to ethical principles is it doesn't take into account the extent to which cultural traditions influence and enhance ethical study and practice. For example, the creation stories, which are the primary reference for Māori ethics, these stories often highlight the nature of relationships, how the world is perceived and the way in which people interact with each other. And these interactions further inform tikanga Māori and the components of tikanga, such as the value of tapu and noa and the relationships to whakapapa and wairua, which in turn provide a framework through which Māori can actively engage with ethical issues, determine the rights and wrongs, and analyse the harms and benefits. And this focus on harms and benefits and relationships is something that's just being picked up in some of the development of the Western bioethics. So our national ethical document is enriched with a range of worldviews that are complementary to each other. In the past, some have also expressed concerns that if New Zealand adopts a universal ethics approach, then specific cultural issues and the existence of a Māori research ethic may be overlooked. As outlined historically, ethics has often been constructed through Western frameworks that may not necessarily be transferable to other contexts and times. Furthermore, Western ethical research has tended to focus on legal requirements and these institutional codes of ethics, which often focus on ensuring benefits and fairness to individuals rather than looking at collective rights or communities. So researchers have designed documents in the past, such as information sheets for prospective participants, long privacy statements and consent forms, very much a focus on the individual, and that's carried over somewhat from the clinical trials environment, the infrastructure that supports that, but we're really wanting to bring these other ethical viewpoints to the way that we conduct research here in New Zealand. Doing novel things like this is something that we're really good at. And just to recognise here the long history of Māori research ethics and its development, this is just a snapshot. The original timeline was about 7 pages long. But Indigenous populations, both internationally and locally, have long traditions of conducting their own research and experiments and developing their own ethical guidelines. Now, the historical and research on these communities is often conducted by Western researchers using Western research ethics who have a poor understanding of Indigenous ethical principles. So it enhances the feeling of disempowerment and exploitation, of which is a huge threat to health research. One of the best, most significant resources that health research has is trust, and we can see that trust isn't the same across the board for some research populations here in New Zealand. So social changes over the past 30 years have both increased the awareness of the value that research contributes to health outcomes, but also health equity, and a reconstruction of what is considered ethical practice, particularly with regards to research with Māori communities. And the Māori research community have worked to develop more respectful research relationships and become agents of research that is grounded in Māori concepts. So you can see this across the board in terms of development of all of these Māori considerations of things like biobanking, use of data, and te ara tika, which I'll get to in a moment. But the key thing that this national ethical document highlights is that we've brought all of this work that's been separate for such a long time into one document. So we've addressed the criticisms that we've seen that have been levelled at the ethics review system and the policy environment for the past 30 years. We've brought together te ara tika and Western bioethics, and we've also brought in frameworks from these other documents into our national document, so they're all in one place and they apply to everyone. So why does research ethics matter in New Zealand in particular? Well, I've given you an understanding of why we have different sources of the ethical principles that I'll be explaining in a little while. Now I'm just going to explain why we need the ethics committees and some degree of ethical oversight of research in New Zealand. So there are, unfortunately, a number of examples of cases of unethical research in New Zealand. I'm just going to look at two of these cases. So firstly, we are looking at the unfortunate experiment and the Cartwright inquiry. So this is often referred to as New Zealand's Tuskegee moment that we had in June 1987 when Metro magazine published the investigative report, An Unfortunate Experiment at National Women's. According to the report, women with cervical cancer in situ had been deceived and mistreated for years at a prestigious Auckland hospital. The revelation led to an official government inquiry, 6 months of public hearings, and most importantly, far-reaching reforms that have effectively prevented any such abuses, particularly of this kind, but I think that might not necessarily be correct. The inquiry also exposed other unethical practices that it picked up along the way, cervical smears being taken from newborn baby girls without their parents' consent, and exposed the hospital's practice of teaching vaginal examinations and IUD insertions on unconsenting women who had been anaesthetised for other operations. During the inquiry, District Court Judge Sylvia Cartwright concluded that Green's work had varied considerably from what was considered good practice and put his own patients at risk. The ensuing report, the report of the Cervical Cancer Inquiry, 1988, contributed to sweeping changes in law and practice around the health and disability consumer rights space. So we see the Office of the Health and Disability Commissioner established in 1994. We have the Code of Disability Rights come into force in 1996. Teaching practice was changed, and this was the first that we had independent health ethics committees established in New Zealand. So that's the first time that we see ethics committees come into force, and in particular that are not institutional ethics committees that are part of the hospital or the university. At the time, I believe there were over 24 of these committees. They are now down to 4. I don't want to get any less than 4 during the SOT review. So we also have the National Cervical Screening Program being established. So this is another example of systematic error. The government ordered another inquiry into the cervical screening in the Gisborne region after it was initiated, after it was discovered that a local laboratory had failed to identify hundreds of abnormal smears. The inquiry examined the practices of pathologist Dr. Michael Bottrell, who owned the laboratory and was responsible for reading the smears. His laboratory found 0.53 high-grade abnormalities compared with a national average of 1%. Once Dr. Bottrell retired in 1996, the rate of high-grade abnormalities jumped to 1.71. So 22,978 slides belonging to 12,108 women who had the smears taken in the region between 1991 and 1996 were re-read. 9,584 women had all of their smears originally reported and reread as normal. However, a large number of women, 1,997, were advised of abnormalities, many of which were previously unreported. It was a persistent effort, again, of one woman that finally brought the issue in Gisborne to light. Between 1990 and 1994, 4 of her own tests were misreported. The first of the 3 should have been reported as revealing high-grade, lesions, and the 4th as invasive cancer. So finally, she was diagnosed with cervical cancer by a gynecologist and had a radical hysterectomy and extensive radiation therapy. By the time she had her treatment, her prognosis was a 40% chance that the cancer reoccurred or metastasizing. Whereas had she been treated with the high-grade abnormalities when they were first detected, her chance of a cure would have been virtually So the Gisborne Inquiry delivered 46 recommendations to ensure the safety and quality of the National Cervical Screening Program. There was conclusions that there was ample evidence that Dr. Bottrell was underreporting, with a wide discrepancy between the results of the Gisborne lab and the Australian lab used for the reread. 16 women developed cancer because of the underreporting. So this case both shaped the need to report incidental findings, but more importantly, it highlights the need for an ethics of quality improvement, as outlined in the National Ethics Advisory Committee standards. So these cases highlight some of the rationale as to why we made some of the decisions around this national document. So now I'm going to go through a little bit of what's actually in the document. So they are our national ethical standards, health and disability research, and quality improvement. So the reason we updated the document, the first was that they were incredibly outdated. This 2012 document was in fact a minor update of a 2009 document, resulting from the substantial changes in 2012. We also had two separate documents, one for observational research and one for intervention studies. This dichotomy is quite a false dichotomy. The information on issues that were relevant to both intervention studies or clinical trials and observational research were different in each document. Just in general, having two documents was unhelpful. The structure of these documents, they were very high level, so the amount of guidance was limited, allowing more points of disagreement between researchers and ethics committee members. They were also in print, so this is a substantial change for our current NEAC standards. And much of the guidance, and particularly in the 2012 document for intervention studies, all of the guidance was put into appendices at the back of the document with no standards on those various forms of guidance, meaning that they were not actually part of the standards. And that's where a lot of the core information was. So a lot of good reasons to change. I've been talking a lot about tragedy and this kind of ebb and flow. Now the key thing to recognise for our current review, as well as these national ethical standards, is that they're not a reaction to tragedy. They were very considered. We had a very considered approach, similar to what we'll be doing with regards to our operational review. We're looking at what works, what didn't. We got the right people involved to create this document. They're responding, as Rob referred to, as an increasingly complex ethical landscape. They reflect ethics that represent New Zealand values and New Zealand culture. They're also a strategic document, and this is something I'm going to talk about a little bit later as well, but looking at what the role of ethics committees are and what the role of bioethics committees are when it comes to strategic aspects such as equity in health. So equity issues underpin this document, and we'll go through that a little bit later. Now, it's a living document, it's online only, and it can be updated incredibly easily. We're also converting it into a HTML5 website, so it'll be easily accessible online. Any minor changes, particularly of the spelling mistakes that we've been dearly informed of after publishing, we can make those without consultation, obviously. But the process by which we'll be updating these standards will be twofold. One will be when NEAC determines that there needs to be a new module. So one example that might be there in the future is looking at emergency research ethics. So research ethics in perhaps post-disaster. So we've already identified a number of areas that we want to consider adding. Really easy to do that, as well as consulting on any further changes, so you won't get any surprises coming through, but it is very much a living document. And the feedback loops that we're referring to here is something that's been developed over the last 5 years or so, particularly with us being more engaged with researchers. But what we want is, recognising that researchers and ethics committees are effectively at the coalface of ethical issues, as well as how these standards are actually working on the ground. So us as the Ethics Secretariat want to work with researchers, ethics committees to get the right feedback and then send that up to these national bioethics committees. So particularly building the relationship between the Health Research Council Ethics Committee and the NEAC Committee. So we've had a lot of positive meetings in that regard as well. So I'd say it's all coming together. And if there is anything that is glaringly not working with these standards, it's something that we can address without waiting 5 years. So addressing the tension, the NEAC standards fulfil a range of functions. They give researchers and ethics committees the language to engage in ethical discussion. They provide tools to know when there might be ethical issues that are raised in research. They provide guidance on how to mitigate or manage those ethical issues. And I have printed it out once, and it is more or less a doorstop in my bedroom. So it is a long document, but necessarily so. So the standards, what they really do is they enable systematic analysis and resolution of conflicts through an evidence-based application of te ara tika and bioethical principles. One of the things that we're acknowledging is that all health research and quality improvement and disability research will have ethical conflicts or tensions that require ethical consideration. The ethical significance of key issues can be understood, analysed, and we can find solutions by using these standards. So one of the things that we're going to do today is we're introducing this framework for analysing the ethics of a research study. This is something that the ethics committees have had introduced as well. In particular, the reason why is that the standards can't cover everything. You'd think with their size that they might, but they don't. So what you need is the ability to understand how to analyse a particular ethical tension in a study using these high-level ethical principles of te ara tika and bioethics. The standards will be supplementary and they are quite exhaustive, so you might not have to do too much of your own ethical thinking of this nature, but it shows that these principles and a principles approach based to ethics is something that you can do in order to make your ethical arguments in these ethics committee meetings. So we're going to do that a little bit later. Now, I'm looking at highlights and the impact. So this is to generate discussion on some of the new concepts and guidance. We're going to break this into two parts, so I'll do as much as I can before I hand over to Joel, who will be doing some of the case studies that we've developed to show how the standards might work in practice. So, what we hear is we want from researchers that they want to know the impact on researchers, how much has changed, what are standards, were there standards before, the highlights of the changes, and some of the themes of the changing ethics landscape. So it is a little bit like comparing apples with oranges. This is for a number of reasons. We had the two sets of documents with a different structure and layout. We brought all of that together into one document. We looked at all of the frameworks that were across published Māori ethics and brought that in as well. So some key decisions. The standards have a strong educative function, so the consequence is that they are quite long. Their standards apply to all health and disability research. So these are the national standards, whether you have to come to an ethics committee or not. These are the standards that will be used if you're under investigation through the Code of Rights. These are the standards for New Zealand. Now they also cover quality improvement, innovative practice and health systems research. This is a substantial change. It's something that's going to take a little bit of time to embed, but we're happy to work with quality improvement practitioners as these standards become to be embedded into the health system. As I stated, the standards apply whether or not you have ethics committee review. Ethics is actually about conduct of investigators. The ethics oversight from ethics committees should only be for particular cases. So we encourage all health practitioners and researchers to read these standards. One of the key things that I think is really important with both my NEAC hat on and my Ministry of Health hat on is having a proportional approach to ethical oversight. So here there are a few examples of where these standards have a risk-based approach to ethical oversight. Using the data example, we have a set of assessment questions that we'll go into a little bit later today to figure out how risky proposed reuse of health data is, and depending on how risky, both ethical risk and actual risk of harm, how risky that reuse is, if it's substantially riskier, we might require consultation with the community around that reuse. If the degree, if it is complex or perhaps the data is of a sensitive nature, will require stronger data governance requirements than another use. And where I think this is really going to take shape over the next year is the complexity of informed consent processes. So we're going to be looking at developing modifications, simplifications to the informed consent process when it is reasonable due to the circumstances of the research and the risk of the research and the research population. So I want to get flexible with informed consent. Ethical review should also be proportionate to the risk involved of the activity. So through this standard operating procedures review, we're going to be introducing some different ethics review pathways to recognise that research is really broad. The expertise that you need for particular kinds of research is different across the board, but some of these activities should have an expedited review pathway, fully online. We do have that to some extent at the moment, but they effectively use the same form. So, we're going to be addressing a lot of those issues in terms of the procedural aspects. But the NEAC framework gives us the ability to do that. It also introduces a new level of risk that's lower than minimal risk. So that again recognises that a lot of these activities, say in quality improvement, they are very low risk, but they are not without risk. So that's a new, a new conceptual consideration. And online only, so they're going to become a website. Very cool. Another substantial change is the structure of the document. So initially when we went out for consultation, we had all of the standards underneath one place and then all of the commentary in another. Commentary does not exist at all in the 2012 versions of the documents. Now this example that I've brought up here in particular is Barry Smith's example. The reason why we put together standards and commentary is these documents, sometimes they are aspirational or sometimes they introduce new concepts, and we don't expect you to know what these concepts are off the bat. So, for example, Standard 3.3 under the chapter of research in Māori, research design must demonstrate cultural rigour in order to meet ethical requirements. So this concept of cultural rigour, Barry was talking about how we obviously would never conduct a study that wasn't scientifically rigorous, that didn't have merit. That would be unethical. So by introducing this term, which again is uniquely New Zealand, of cultural rigour, it puts cultural considerations on equal footing as the science and design of studies, which I think is really important in New Zealand. So here the commentary underneath the standard 3.3a, b and c, it explains what we mean by this and how as researchers you can consider the standard among your own research. So for example, cultural rigour considers, among other things, the application of cultural concepts, norms, practices and language in the research process that actively protect Māori individual and collective rights. Cultural rigour can be ascertained by conversations with Māori, especially experienced Māori health researchers who understand the purpose of rigour in research contexts. Now, proportional, again, you might not want to go and bother experienced Māori health research for every single study. A lot of what we've talked about in terms of at the last roadshows is getting the engagement right for the right studies and understanding what that looks like when we realise, again, the important and scarce resource of Māori and health systems always being asked to provide informal reviews. So we want to manage that tension of increased engagement without overburdening. So if you are not in your study potentially going to go and talk to an experienced Māori health researcher, you can actually ask your questions of yourself. So here we might ask, what might this research offer to Māori communities? What questions should the research try and answer to improve the well-being of Māori communities? And what methods are best to use to conduct research with Māori communities? Now, we're also recognising the role of identity and the role of someone's own values and experience that they bring to the table, and acknowledging that that actually matters in terms of the shape of research and in terms of the research outcomes. So if a researcher is of non-Māori descent, the researcher must answer these questions. Am I the right person to be doing this study, and why? In what ways does my cultural position help or hinder this study? And do I have any conflicts of interest that may impact my objectivity? So this is an example of a new standard where we want people to ask themselves the right questions. We want to see that thinking start to happen, and that's right at the start of studies as well. Now, another key change, increasingly health research and quality improvement, it involves responsibilities that are broader, that extend to institutions and organisations. So the standards do use the term researchers or researcher throughout when referring to corresponding responsibilities. But the standards actually use the term researcher very broadly. So in particular, the standards address all those responsible for the conduct of health and disability research and quality improvement activities. Some of the examples of where this is apparent is data and tissue governance. So often a researcher is part of a community or an institution of which they have their own rules for data governance, data management. We see areas in the standards that are not necessarily researcher driven, for example, custodians in biobanks, custodians in data registries, so a much broader understanding of the obligations. Now, even in some aspects of these standards, we provide specific guidance for institutions as opposed to researchers. So that's again in the data governance chapter. We'll go into that a little bit later. All right, what is new? So I've done my best to just think about, what are some of the new aspects of these standards. Now, the best way to show you what's new is these entire chapters are all brand new. So the partnership of principles that I'm going to go into detail shortly. Disability research, we've got Gordon presenting on this, and this was a huge learning curve for myself, and we had a fantastic process that actually I believe is being written up in a paper on the way we engage with community on developing this chapter. Research benefits and harms. This is a key chapter primarily for researchers to have the language to communicate with ethics committees. So to understand what makes your research something that should be done and how you've managed or mitigated all of the harms in your research. Ethical management of vulnerability, this is something we'll talk about a bit later today as well, but we've moved away from the conception that groups are vulnerable. Instead, we look at the sources of vulnerability, what makes someone vulnerable, and it's a much more nuanced understanding of vulnerability. Everyone can be vulnerable. Vulnerability can be wavering, so it can come and go. So I think it's a much fairer understanding of vulnerability in health research. Human tissue in biobanks, if you control F find tissue in the 2012 documents, there are 0 returns. Kind of amazing. There is guidance at the time from the Health Research Council, but this reflected that fragmented ethical guidance situation that we had in New Zealand. So these chapters are brand new. They are up to speed. They have been developed in partnership with Māori researchers, in particular Maui Hudson, who put so much effort into his work with Te Mataira and also Te Aratika. So, having the New Zealand view and values come through with regards to use of tissue in health research and storing that tissue. Health data. This is probably one of the biggest new revelations in terms of ethics getting a bit of a resurgence, both nationally and internationally. One of the difficult things with developing national ethical standards is you obviously always publish them or develop them at a certain time where ethics is developing and evolving. And we're seeing data and data ethics be a kind of a resurgence of ethics internationally, driven by concepts such as machine learning, AI. So we had to effectively provide the first national ethical guidance, again internationally, on new technologies and artificial intelligence. So we'll talk a little bit about that later as well. Stem cells and reprogrammed cells, again, some particular areas through our public consultation came through as needing particular ethical guidance, so we addressed that, again with working groups who understood the technical aspects of this research and paired them with the right people who could then consider the ethics of some of these new technologies. And of course quality improvement, so that's a brand new chapter of the standards. Guidance, concepts or themes. So people, when the standards went live, I was asked how, whether I think a lot of studies would have these new ethical problems that they'd have to deal with. And I don't see the NEAC standards as creating any new controversial standards in the health research ethics landscape. What it did was it made it clear what people were either already doing or developed further the existing ethical guidance. Some of the other changes are not so much this is a new standard, but it's about a new approach to health research ethics and some of these new concepts or themes. So first off, a very practical example, we did put a lot of new guidance on determining whether an activity is research or not. This is an issue that's always faced by our ethics secretariat, likely by research officers as well. But it is a really important distinction in terms of, say, access to health data for an audit versus research. So we tried to provide clarity to the sector on how to get that determination right. An example of the change in concepts or emphasis is consulting and engaging earlier with communities, and this general push to having consultation happen earlier on rather than at the end where you say seeking locality review or after ethics committee approval. So we realised that this has practical implications, so we're working with the locality review officers, and we'll be doing work to try and facilitate some of the processes behind some of these aspirational ethical standards. This is the direction that we want to be heading. It might not always be possible off the get-go, but that's the direction of travel, and we're talking about that a little bit later as well. Equity lens to health research, so similar as engaging in consulting earlier. I'm going to go through a few documents that have equity as the core strategic focus, and we're starting to think what the role of ethics committees is with regards to the review of health research. Modifications to informed consent. So we have provided a lot more different kinds of informed consent, some of which is not really used in New Zealand at all. So this is a real opportunity to develop some new templates, frameworks, and start to popularise a comfort level with consent that might look a little bit different. And this applies both to supported decision making as well as simplified consent. We're looking at health data governance and management. I will go into this a little bit later, but one of the big challenges in developing this document is that we lost two of our biggest protection measures with use of data. We're, if not already, very close to being in the age where identifiability is not a protection. Everything can be re-identified. Now that's a huge blow to ethics, which often relied on de-identifying data to make it more reasonable to send data far and wide. So we're losing a protection there. The other thing we're losing is the meaningfulness of informed consent for use of data. The reuse is on a scale that renders a lot of those informed consents as more similar to a future unspecified research consent or a blanket consent, which aren't very meaningful. So we've had to shift how to respect people in, say, the absence of informed consent for use of data, or in the absence of having that data be de-identified and therefore of lower ethical risk. And to address that, we've moved towards data governance and management, looking at access issues, looking at why certain reuses are happening, and looking at the relationships between the researchers, the data itself, and the community from which it comes. So this approach, again with Te Ara Tika, which focuses a lot more on relationships than Western bioethics, hugely important when looking at data ethics. We'll get into that a little bit later on. We have strengthened the waiver to use data and tissue without consent. We'll go into that a little bit later. Health systems research ethics. This is a fairly substantial addition to this document. I'll explain what health systems research ethics is, but it also generates a number of ethical tensions, particularly when it comes to informed consent, cluster randomised trial designs. So NEAC has been working really closely with the Health Research Council Ethics Committee and the Health and Disability Commission on some of these ethical legal tensions. So we'll get to that as well. Comparative effectiveness research, so this is in relation to the increased embedding of research into routine clinical care. This is a shift in the kind of historical distinction from research and treatment being always separate. We're going to see a muddying of the waters and I think an increase in the world of grey in terms of health research, happening more and more in these clinical contexts. Lastly, supported decision making. We've provided a lot more guidance in the document on what this looks like. This is highly relevant for increased engagement with disability research, but also looking at our ageing population, dementia research, so having safe ways of respecting people and having them be included in research and not just always jumping to a waiver or excluding them. Lastly, this is going to come pretty much after we finish the roadshow. We're going to be working straight on some of these new templates for informed consent, templates on what data governance frameworks will look like, providing guidance as much as possible once we start to see how these standards are working in practice. The new application forms, they'll be developed that will reduce so much duplication. We'll be working with the Health Research Council and seeing, whether there is alignment that we can have across these different systems. And following each one of these roadshow days, we're meeting with the institutional ethics committees and seeing what alignments we can have with them as well. So we are always trying to make these things easier for you. And more consistent guidance. So because these standards are very much highly detailed in terms of the commentary, we do expect that once they have embedded over the next 6 to 12 months, that the guidance that you'll be receiving across the country will be more consistent, particularly when aligned with some of these operational changes. Okay, so I'm just going to quickly have a look at the agenda since we've changed the timing. I'm just going to continue on a little bit and then I'll have some general Q&A. Okay, so taking into account that historical separation of Māori and Western bioethics, our national standard set out 2 sets of principles that collectively form our national ethical standards. This is something unique to New Zealand. I've never seen anything in an international document that has Indigenous bioethics and Western bioethics side by side. Te Ara Tika is the set of Māori ethical principles that draws on the foundation of tikanga, so Māori protocols and practices. Te Ara Tika means to follow the right path. So in this document it's used as a generic set of principles commonly shared by many generations and communities of Māori. However, they have application to all people in Aotearoa, New Zealand. The bioethical principles that appear here have been used in many, many sets of human research ethical guidelines, so you'll see these in most documents internationally. They have carefully established and developed implications as they have been widely used, but they also have their limitations. So what I'm going to do now, this is the first time that we've done this, is go through each of these principles and what they mean. When we consulted, when we were doing consultation meetings, we basically said we were doing this because we felt like that was very important, but today I'm going to explain how these actually work. So we've done this by turning the definitions into questions that you might ask of your own research in order to meet these ethical principles, in order to navigate some of those ethical tensions. So tika refers to what is right and what is good for any particular situation. Tika highlights the value of engagement, of asking communities about what research questions are important to them. Although the quality of the information produced by research depends critically on the scientific value of a study, scientific value alone does not make a study socially valuable. For example, a study could be rigorously designed but lack social value when either the research question has actually already been successfully addressed in either prior research or through the community, or alternatively, if the study question is not appropriate for the community. It may be well designed but not ethical to conduct because it won't generate any social value. So that's one of the things that you can take away from tika. Have communities been involved? Where did you find this study question? And again, not to have researchers discharge their obligations, but if you talk to communities about what the ethical issues are in that study, they can do a bit of that work for you, as they often know. Same thing with designing patient documentation, participant documentation. Engage with communities, and we'll get into that a little bit as well. Beneficence. So beneficence is about individuals and communities, and it implies improving or benefiting people's health or broader well-being. It's both the basic aim and fundamental justification of good research. Health research should be designed, conducted and reported with the intention to improve outcomes, and beneficence requires that those projects do have scientific merit. The value to the answer of a scientific question posed by a study must be worth the risk, inconvenience and resources that contribute to answering it. In order to be ethically permissible, health and disability research with humans, including research with human tissue or data, must have social value. And the scientific and social value can be difficult to quantify, but generally it's grounded in three factors. The first factor is the quality of the information that's likely to be produced by the study. The second is its relevance to significant health problems. And the third is its contribution to the creation or evaluation of interventions, policies, practices that promote individual or public health. The idea of what counts as a benefit is also something that may differ between individuals and communities. So researchers should take different views into account, either through the informed consent process or engagement with communities, to understand what a benefit is. Now this is relevant for the benefits and harms chapter, which gives researchers tables of different benefits and who they accrued to in terms of conducting health research. So recognising that absolutely participants can benefit, but researchers will always benefit, institutions benefit, understanding that there's a wide range of benefits and people who would benefit, but also real risks of harm. So you can see the questions here as well, and asking these of your own study will help you meet the principle of beneficence. Manaakitanga. So this refers to caring for others, nurturing relationships and being careful in the way that we treat each other. Aroha, respect, love, generosity, sharing and hosting are essential parts of manaakitanga. And it allows us to uphold the mana of all parties. So, you don't really see love in Western bioethics, but I think it's a really key factor, particularly also the concept of hosting. So again, bringing in the institutions and the fact that, these studies and the relationships between researchers and participants don't occur in isolation. They're all actually connected to the wider research infrastructure, as well as the kind of research endeavour, and I'll go into that a little bit later as well. So again, looking at the relationships in the study, respect, privacy and confidentiality, and looking at research partnership. So again, this is something that is relevant and is throughout this document, looking at research not as a one-off, but the opportunity to develop long-term research relationships, whether that's through registries or research partnerships. So looking at all of the other possibilities that are within each research project. Non-maleficence. So non-maleficence requires researchers to avoid causing harm to individuals or communities, or at least to cause the least amount of harm possible. At a community level, potential harms may place an inequitable burden on a community without providing them a compensating benefit. So researchers must put appropriate places to minimise risks of harm and effectively respond to any harm to individuals or communities. One change in the document is you're going to likely be asked for management plans, not for just full-on clinical trials with new medicines, but also for your social research, having a plan in place for incidental findings that are not necessarily clinical but maybe emotional, thinking about mental health. So I guess the focus on being prepared for some of the potential risks of harm in your research. That's going to be a new focus. So we have less ad hoc management of harms that occur in research. The potential individual benefits and risks of research must be evaluated, and it's often done in a two-step process. So firstly, potential individual benefits and risks of harm for each individual research intervention or procedure must be evaluated. So looking at every single thing that is done to someone or with someone in a research project, is that necessary to answer the research question? And are the risks of harm that it takes to get that information worth that corresponding information? So doing that for every aspect of a study. The second step is the aggregate risks and the potential individual benefits of the entire study. Now that has to be assessed and considered appropriate. Now this is a difficult thing, and this is what ethics committees have to do all the time, is they have to look at the actual risks of harm to real people that are in that research project and consider whether those risks are acceptable for potential future people. And the study may not produce those benefits. So it is it's an inherent risk of research, and it's why we constantly have to minimise the risks as much as possible. So those risks need to be considered appropriate in light of the potential benefits to participants, as well as the scientific and social value of the research for future people. So it's real risks of harm for something that we hope to produce for future people. It is quite a big ask. Whakapapa. So this also refers to relationships. However, the term encompasses the quality of those relationships, the reasons for their formation, and the structures or processes that have been established to support them. The relationship between researchers and participants and New Zealand communities must involve trust, respect, and integrity. As referred to earlier, that relationship between researchers and clinicians and communities is one of the most valuable resources in terms of having high levels of recruitment and having people be confident in the research sector. Part of my PhD that I was working on looks at these relationships potentially changing as research becomes more and more involved at DHBs, and I think that we're going to see the shift of people's expectations around what a health system does in terms of research and treatment shifting. Whakapapa also reminds us that an individual is always part of a whānau or wider collective. And this then looks at new concepts under informed consent, such as collective decision-making, collective information sharing, collective participation in either the consent processes or just general collective support for the research data collection, as well as looking at the end results of research, so data analysis and dissemination of results. Researchers ultimately need to assess an individual's own preferences in terms of their collective support networks. Mana. Mana refers to power, prestige, leadership or authority, either bestowed, gained or inherited, individually and collectively. And it infers that each individual has a right to determine their own destiny under their own authority. So mana is an influencing factor in leadership, interpersonal and intergroup relationships, including those entailed in research. The shared knowledge upholds the mana of research participants. Mana also has ties into equity and distributive justice in terms of potential or actual risks, benefits and outcomes. And it also looks at those power and authority relationships between participants and researchers. And we go into this in the sources of vulnerability and understanding unequal power relationships. Lastly, the principle of mana requires that research processes uphold aspects of tikanga Māori and looking at local procedures. So again, understanding local factors. Respect for people. So this underlies the general human rights principled approach, similar to autonomy, but it's also significant in cases where autonomy isn't entirely present. So for example, in particular, a person's capacity to exercise informed consent, if that is reduced to some extent. Autonomy being a broad concept, typically in the West was thought of individual autonomy, but something that we want to recognise here is also relational autonomy, so understanding autonomy that is actually shared across a number of people. So this recognises that a person's autonomy can change, and it can change over time, and it can change depending on the nature and context that they find themselves in. So diminished capacity also may be permanent or temporary, and we've acknowledged this in the standards, and we've widened the group of people that we consider able to make informed decisions that would actually represent informed consent, but it may not look like a traditional informed consent. So we've recognised that, and we've recognised the ability for people to have adequate support, and again, developing New Zealand's research capacity on supported decision making is another focus that's going to come down the line. Justice, last one. Justice requires that people are treated fairly and equitably. So this is both looking at fairly distributing the benefits and burdens of a study, both on individuals as well as populations. The studies should be designed to obtain knowledge that benefits the class of persons of which are the participants or they represent. The class of persons bearing the burden should receive an appropriate benefit, and the class primarily intended to benefit should bear a fair proportion of risks and burdens for the study. Again, if you look at the history of research, much of it in terms of being exploitative was doing it on one population and the results going to another. You see this as a huge issue in global research, where researching in lower income countries from sponsored and well-developed countries, and that knowledge just going straight over. So, it's something that we have to think about here in New Zealand as well. Justice, and it kind of links quite well into this, justice does involve reducing inequities in health outcome. So looking at research questions and processes that are relevant for New Zealand, and looking at how every case of research could reduce inequities in health and well-being between populations. On the flip side, researchers should also consider whether their research may increase inequities, and if so, how they're going to mitigate that potential effect. You could have really well-designed, well-funded research in one particular area, but the health outcomes for that population are already better. So by improving it further, you are in fact increasing inequity. So some things to think about. So what will end up, fingers crossed, and this is what we see at the ethics committees in terms of the process, is on one hand we have our values that we bring as individuals and communities, and we cannot disregard those values. We bring them to the table in any ethical deliberation. We also have consensus decision making, so particularly at the committee level, this is how it makes us put all our values on the table, be transparent about it, and discuss what we're about to see here, so the facts of the case, using those ethical principles that we've gone through, supplemented by the ethical guidance and analysis, which is in the NEAC document, and hopefully resulting at ethical decisions. Now across the top there, this is perhaps a new aspect to ethical thinking, which is the equity focus, driven by the health research strategy and driven by now the NEAC standards. So looking forward, adding an equity lens to health research ethics. So equity is found in both of the ethical principles that we have, Te Arotika and Western bioethics, and it aligns and is closely related to human rights principles, particularly the right to health and the enjoyment of the highest attainable standard of physical and mental health. It's been a key focus in a number of strategic documents coming out on the health sector, and it's driven, as I say, primarily by the health research strategy in terms of its impact on us at the National Ethics Committee level. So what is equity? So it's the absence of avoidable, unfair or remediable differences among groups of people, whether those groups are defined socially, economically, demographically, geographically, or by any other means of stratification. So here in New Zealand, obviously we also look at different ethnic populations and those health disparities which are ever present and we may hear about later today. So we're saying that equity should be a priority focus for all health research activities. So how does that look? So two areas of importance in terms of inequity, not just between Māori and non-Māori, but we're also looking at people with disabilities having inequitable health outcomes. We also have a chapter on Pacific peoples. Again, that's brand new, and they also experience health inequity. So we have some strategic priorities that we want to focus on, but this is a shift in terms of the Ethics Committee's role, and it's something I don't think we've fully figured out yet. So, for example, in 1993, it was recognised that the next big challenge is to recognise ethnic inequalities and the need to actively eliminate them. But if an ethical dilemma is that if every Ethics Committee doesn't ask, how will this maintain or reduce inequalities? If not, why not? Our ethical practice is part of the ongoing maintenance of the acceptability of inequalities in this circumstance. So I think that we're going to be having more of a discussion at the Ethics Committee interface on whether the researchers have thought this through. How that comes out as perhaps questions, again, for general considerations around inequity. Is it a priority area? To who and why? Are there key relationships that have been engaged when and what happened? Will it achieve equity? How are you going to measure this? For Māori, looking at Indigenous rights being met, tikanga being incorporated and who's overseeing this, and potential for Indigenous innovation, so workforce development for Māori, looking at incorporating language. Down in Christchurch, our speaker kind of brought to the focus the number of things that you can do to increase Māori research capacity, both small and substantial, and realising that particularly doing as much of the small stuff as well and incorporating it into the full design of health research. So that's one of the things that we might be seeing. Another new trend is really recognising the increased role of consumer and patient engagement in developing research. So this is one of the trends coming out of the Australian Clinical Trials Alliance. So they're a body that's working with the Health Research Council and the Ministry of Health and MB on the health research strategy. They have a number of streams of work, one of which is increased consumer and patient engagement. And it's about the changing relationship with the public. So this isn't just about researchers being more involved with consumers. It applies to bioethics committees and the ministry as well. So looking at some of the ways perhaps our bioethics committees can be more involved with consumers in research. So, we did have a number of consumers at our public consultation, but not perhaps as many as we could in future. And there are different levels of involvement, and increased involvement is really well understood, for example, in disability research. So there are pockets of gold standard, throughout New Zealand in some of these areas, and I think that that's what we need to tap into in order to bring up bring through some of these I guess, ways of working in health research that are already happening in a lot of areas. But you can have individuals that have personal experience and motivations, or you can have expert consumers. Different consumers have different roles, but there are a lot of valuable consequences of engagement with consumers early on. And one of the big things, which is why we included health systems research into our NEAC standards, that New Zealand is really good at doing health research, but we're not very good at implementing research. So consumer engagement at the beginning of studies have shown that dissemination and uptake is higher overall. So again, how can they be involved? Setting research priorities, planning and design of research, the conduct of research. Particularly, I think one of the things you can do off the bat is having better patient or participant-related documentation, surveys, questionnaires. Evaluating the research results, figuring out how to get the impact of all of this research that we're doing, actually changing practice in New Zealand. So that's a huge focus for the health research strategy, and new funding grant rounds have gone out on looking at building that capacity for New Zealand to do better implementation research. Dissemination of research findings, and not simply recruiting patients as participants in clinical trials, but building those networks. So again, networks are something that we're likely to see more and more of in New Zealand. Just an example of this, coming through. So this was published around the same time as the NEAC standards. It's the Health Research Prioritisation Framework. And it's looking at a lot of the things that I've been talking about, and I suggest having a look at it. It is that changing nature of health research. It's becoming strategic. Research for research's sake isn't going to cut it. We're going to have to actually look at achieving some of these outcomes that we've been trying to do for such a long time, but to be honest, are not necessarily getting anywhere quickly. So I think that this strategic approach is something to really be aware of when designing your research. And just start to think about building some of those relationships. There was a 15-year retrospective look at Nature, looking at ethics in health research. It's called The Long and Bumpy Road from Shirked to Shared. They say that ethics used to be from all too scarce to professionalised. The ethics of research is now everybody's business. So the pursuit of a more ethical science or health research, it's become more associated by building trust, creating transparent processes, inclusive participation, and an openness to uncertainty, as opposed to distinguishing between is and ought, or overly academic justifications. So the implication of this new model is that most ethical science is the most sociable one, and thus scientific excellence depends on greater inclusivity, and that's the direction that we are seeing in both, was always present in Te Ara Tika and Indigenous documents, recognising those relationships, and I think Western ethics is just catching up with some of those key considerations. So as bioethics evolves, as does any other branch of knowledge, we will continue to build trust, we'll build our relationships with you, and we'll strengthen the health research landscape in New Zealand, making it a lot clearer as it's been fragmented for a very long time. So I'm just going to close off this section today. We will revisit the highlights and some of those concepts that I talked about earlier. But to summarise ethics, it's about navigating tensions and conflicts between principles and values. Ethics in the research environment is always changing. Ethics committees and researchers have to work together to confirm that each case of health or disability research determines that it's a good thing to do, both for the individuals and for future people, and that it's being done in the best way possible. The NEAC standards, in conjunction with the upcoming operational changes, will support ethical decision making, it will support consistency and research excellence overall. So today we're going to highlight a few further aspects of the standards. Joel's going to introduce this framework for analysing some of those ethical issues. Do get involved and if you want to. But really what we're doing is sharing perspectives, values and finding common ground. So we consulted on this statement, he waka eke noa, a canoe which we are all in with no exception, and that truly is how NEAC and how the ministry feels about ethics. You know, it's everyone's business. It's not just about the ethics committees themselves. It's about the practice and the way that you form those relationships with your research participants. So I will be quiet for the time being. Thank you very much. And I'll hand over to Joel.